do this. Okay. As I'm admitting people in. Wonderful. Well, thank you everyone for joining us on another conversation. Let's talk about cancer. Today we have our team leader, Dr. Jennifer Hatcher. She is the Associate Director of the U of A Cancer Center Community Outreach and Engagement. And we are very excited to continue our conversation with cancer and how we progress in our own efforts. Again, my name is Gabriella, and I'm a cancer health educator, and I'm accompanied by my colleague here, Monica Yellowhair, Dr. Monica Yellowhair. And we're very happy to start this conversation, so let's get right to it.
All right.
So Dr. Hatcher, would you be willing to introduce yourself and tell us a little bit about your own background?
Sure. Though that wasn't one of the questions you sent me, I'll be happy to introduce myself and tell you a little bit about my background. So I'm the Associate Director, as Gabby pointed out, for Community Outreach and Engagement at the University of Arizona Cancer Center. And I am a nurse by training. I've been a nurse for more than 30 years. And I'm also a scientist, a researcher who uses community engaged strategies to do research primarily on prevention, cancer prevention and control in vulnerable populations. And I have done a variety of research studies over the last 15 to 20 years across diverse populations to help them connect with cancer control. So I'll leave it there and we can talk more about it as we move through, unless you want to know something more about what I do.
Yeah, well, along those lines, as the director of the UA Cancer Center Community Outreach and Engagement, what is the main goal of this team and how does your own leadership help move these goals forward?
So community outreach, that's a great question, Gabby. Community outreach and engagement is a central part of the University of Arizona Cancer Center. It's a central part of all cancer centers, particularly those who have the comprehensive designation by the National Cancer Institute. So that designation by the National Cancer Institute means that they get to kind of prescribe what we do and we get to use the strategies. So you pick someone who's experienced in using strategies that engage communities. But basically the National Cancer Institute tells us that in order to be a comprehensive cancer center, your COE, which is our team, needs to equip and connect the cancer center with the necessary tools to provide relevant research, education, treatment of cancer for the communities that they serve. And so it requires that we understand the communities that we serve, we understand the communities around us, we understand cancer, cancer treatment, cancer prevention, cancer control, and quality survivorship of cancer. And so in order to meet the mission that we have to provide that kind of connection to the cancer center, my leadership helps us to develop those strategies and helps people like you and Monica and the other folks on our team to connect, who represent our communities, to connect us with those communities in order to give us a bi-directional communication with them that helps us to understand who they are and what they need and helps them to understand who we are as a cancer center and what we can provide. And so we hope that COE provides the glue between the community and the cancer center.
Thanks, Dr. Hatcher. So as a nurse by training, how has that experience / expertise impacted your current role as the Director of Community Outreach and Engagement?
That's another good question, because I believe that the clinical expertise that I bring to this position, I've been, like I said, a nurse for more than 30 years, and you're never not a nurse. Once you're a nurse, you're for me, and probably for any other nurse, you're always a nurse. So that training has allowed me to bring strategies to the table that connect us with communities. My background is in intensive care, critical care, emergency departments, and surgical recovery. So as I was a nurse across the country, in various places across the country, I've done nursing in Massachusetts, in California, Louisiana, Alabama, a variety of places. What I noticed is that people have different health outcomes based on who they are instead of what we know. And so the ability for us to now for me to take that and try to understand why do they have these different outcomes has translated into health equity research. So after years of being a nurse and understanding health and how people experience health, I became a researcher to try to understand why they experience health that way, and if I could help to influence the way that people experience health, and to try to drive health equity and eliminate health disparities. So those health disparities are differences in health outcomes for different people based on who they are. And it's my passionate concern with people not experiencing optimal health, but experiencing the health that they get because they belong to a vulnerable population. And so that experience led me to become a researcher, and I believe it has a huge influence on how I lead this team of community outreach and engagement. It also helps me to understand clinically what people are going through and how they experience, health in a clinical way. And then the PhD or the research side helps me to understand how to design high impact studies that help to kind of fix the root causes of those health inequities.
That's very, very interesting.
And now throughout all the layers that come with helping our own community members, what do you think makes this team, the UAZ Cancer Center COE team, an important asset for community members, specifically across the state of Arizona?
So I am super happy that you asked that, particularly as one of the team members, because one of the things that I'm most proud of is the team that we have on COE. We have a team that's representative of the populations in Arizona. And so we have bilingual folks, we have people who speak Spanish, who speak Navajo, who are from the communities that we're trying to serve. And that is critical for me in trying to reduce health inequities, is having the perspective of those communities. So we've assembled a team here over the last 2 years that include people who I believe have huge expertise. We have a very skilled team. We have a very passionate team, and we have a very representative team. And that's not by accident, that's on purpose. You all were selected because you're skilled and you're passionate, and also because you represent the communities we serve. And I think that helps connect us to the communities and gives us that bi-directional communication that I was talking about. It gives us the ability to communicate and meet people where they are, and also the skill set to give them what they need, and also the skill set for us to understand what the Cancer Center is doing and be able to communicate that in a meaningful way to the communities that we serve.
So you're speaking about the various communities of Arizona. What would you say are catchment areas for our specific COE team, for people who do not know that have joined us?
Right, so a catchment area, that's a thing that we've all had a crash course on our team, in case we didn't know, but let me just start by saying what a catchment area is. So, and I think maybe we've spoke about this from other perspectives. Dr. Contreras probably spoke about this because he's one of our key team members who helps us develop our catchment area research. But a catchment area is the area surrounding a cancer center that you want to have your deepest impact on. It's the area where your patients come from for treatment. It's the area where your clinical trials are conducted. And it's the area where your research is conducted and where you conduct outreach. And so for us, the catchment area is the 5 southern counties in Arizona. I'm getting a lot of feedback here, so if the host could mute everybody but me, can you do that, Monica? Because there we go. Gotcha.
Yeah,
right.
Yeah, it's done. Yeah.
Oh, thank you. The catchment area for us are the 5 southern counties in Arizona. And those 5 southern counties I'm sorry, I'm losing my train of thought because I got a lot of feedback there. But let me get back to it. Those 5 southern counties, 4 of those counties are on the border of Mexico. So that means our catchment area is fluid between the US and Mexico and includes a significant Latino population. About 40% is what we can capture with our statistics, but we know that since 4 of those 5 counties border Mexico, that's fluid, and it should. So I consider us a majority minority kind of catchment area because at any given time we may have more than 40% Latinos within our catchment area. Our impact area spreads across the state of Arizona. We're the only National Cancer Institute designated comprehensive cancer center situated or centered in Arizona. So therefore we have a responsibility to the entire state, but that our impact, our largest impact is in that 5 county area surrounding the UACC in Tucson. We also know that we have within that catchment and impact area 22 federally recognized tribes. So we have partnerships and responsibilities to them. We have a lot of rural and frontier areas. So we try to understand the cancer burden and the people who live in rural and frontier areas in our state. So we have a very unique and diverse catchment area, which means for the COE team, we need to understand the cancer burden. We need to understand their social determinants of health. We need to understand how they experience cancer, what it's like to be within those communities, and what their care is like, their access to care, and everything that we can understand about the people in that catchment area that allows us to provide the most relevant and culturally rich experience with cancer, before cancer, and after cancer, and the elimination of cancer for those populations. So I think I covered our catchment area fairly well. We strive to understand it in great detail, but for the most part, it's that 5 counties, southern Arizona, those 5 counties in southern Arizona. And like I said, our impact stretches across the state. Our office of COE is located in Phoenix, Maricopa County, the most populous county in the state, and our reach is across the state and certainly central to Maricopa County as well.
And given all of our sentiment and this responsibility to continue to really support communities and continue the education on cancer awareness within all these catchment areas, how do you see the COE team moving forward in the next, say, 5 years with all of our goals?
That's a great question. The next 5 years, we hope to continue to grow our impact both within our catchment area, outside of our catchment area, regionally, and in fact, globally. We want to be sure that we're serving the people who surround us, that we're concentrating our research on the cancers that impact them the most. That's why we try to understand our cancer burden and very intimately. We have partnerships with the Arizona Department of Health Services that helps us to understand what that cancer burden looks like. We hope to continue to develop that partnership, making sure that we understand our cancer burden and our people in our catchment area and impact area even more. I see our influence going more than just within the state. I see it being regional. We belong to a Four Corners collaborative, the Four Corners states. We all get together twice a year to try to understand the cancer burden in the region in the Four Corners states. And we have similar populations, so to understand and share strategies. So I see us solidifying that partnership and going even deeper with that, but also having more global influence. We have the Navajo Nation, who we know is hugely impacted, for example, by COVID-19. And they're, from what I understand, the 3rd most impacted in the country. So, you've got New York, probably New Jersey second, and then Navajo Nation. And Doug Ducey talked about that when he made his announcement the other day. And so we want to be sure that we partner more strongly with the Navajo Nation to understand their needs in addition to cancer, their needs in general, and partner with them to meet those needs. I see that developing more in the next 5 years, strengthening that partnership with not just Navajo Nation, but our other American Indian partners across the state. And I see us being more regionally impactful and also globally. Like I said, we're on the border of Mexico, so we certainly have a huge influence on the health of people across that border on both sides. I see us strengthening those partnerships and being sure that we're taking a global look, but for sure I see us taking care of home and making sure that within our catchment and impact area, cancer disparities and inequities are decreased and hopefully eliminated. Do I think we'll eliminate them in 5 years? Probably not, but I hope we make a significant footprint in decreasing those disparities in the next 5 years.
We're very hopeful of that.
Yes. And so I think one of the ways how we can strengthen our partnerships with communities is our office offers some small community grants. Can you tell us a little bit more about those community grants?
Yeah, so I'll talk a little bit more about what's maybe not so small in terms of the community grant here with the $50,000 a year partnerships that we're going to be offering to communities across our impact area. And the real purpose of the grants that we're going to offer as a COE team office to our partners is to have community inspired ideas that we join as scientists with them to take to sustainability. So we hope that the community brings us their priorities, tells us what they're interested in terms of cancer and cancer prevention, cancer control, cancer treatment, or whatever their ideas are. And we take those ideas, and with our scientific expertise, we partner the right scientists with that community member. And then over the next couple of years, they develop an idea that turns into a sustainable idea for that community. And therefore, helping in whatever way the community sees us, helping them to further their priorities on cancer. So for example, a community member could be interested in diet and the diet interaction with cancer. We know that there are 13 obesity-related cancers, for example. And a community member or organization could be interested in how a certain kind of diet impacts their ability or their chances or their risk of getting cancer, or how it impacts their cancer treatment, for example. And so we can pair them with one of our basic scientists who studied diet gene interactions, or one of our scientists who studies from the gut group, who understands how diets interact with your liver, your pancreas, or other your DNA, or whatever it is that our scientific expertise can help that community member. And together they can plan a project that will span 2 years, and we'll give $50,000 each of those years for 2 to 3 years for them to develop that project and work within that community. At the end of that time, we hope that they're ready, and we're going to help them to be ready to take that to another funding level, so that maybe PCORI or the National Institutes of Health can fund that in a way that allows another 5 to 10 years. At the end of that time, we're interested in sustainability within those communities. We hope that whatever intervention we found, whatever discovery we've had, whatever we've understood more from the science that we've conducted for that 5 to 10 years can be readily accessible to those communities. And that's the way that we increase health equity, that the communities that don't always get that kind of science targeted to their needs can now have science that is specifically about what they're interested in, how they want to do it, and how we can bring our expertise to them. So those community grants are an exciting way for the Cancer Center to partner with communities to move forward the science that uses community engaged strategies.
And Dr. Hatcher, you also lead a lot of several different projects and teams, and a lot of things that you are also involved with. Can you tell us a bit about what the purpose of the Community Advisory Committee is, known as CAC, at the UA Cancer Center that you're currently leading?
Yes, so as a leader of community outreach and engagement, And the team and I have put together from across the state a group of stakeholders who can help advise us on the best way to reach our communities, to conduct science within those communities, to address the community priorities. So we very carefully selected partners that we, from across the state, that represent our federally qualified health centers, that represent the communities that I spoke of, the Latino community, American Indian, rural communities, the people who are stakeholders across the state who come to the table and advise the Cancer Center on what they should be doing within those communities and what is the most respectful and culturally appropriate way to do that. This is a very important part of every comprehensive cancer center. And for us, we just started this team in 2019. There are different community advisory boards, but this is the one that's central to the Cancer Center. They have a direct line to the senior leadership of the Cancer Center. Their recommendations are taken seriously and we act on the recommendations. They have policy recommendations. They have recommendations for cultural competence. They have recommendations for what our priorities should be. And that's the main tool for our bidirectional communication. They communicate to us what the community's needs are, the priorities, everything about our communities. We communicate with them what our science focuses are, and what the things we are doing are. And together we devise a plan for the Cancer Center to be relevant, to be sure that our research, our education, our outreach, everything we do is relevant to those communities. So the Community Advisory Board or committee is a central part of the Cancer Center, and the National Cancer Institute actually designates that they be a central part of every comprehensive cancer center.
So with the communication, trying to keep in constant communication with the various communities that we work with, and in the time of physical distancing that we're going through right now with the whole pandemic happening, we are all starting to adapt new ways to communicate, especially going through online forums. How has the use of technology helped you conduct research within various community venues?
That's a great question, because like you said, we're in a time where it's very challenging to communicate with our communities. We have historically been a real face-to-face, boots on the ground operation where our community health workers are out in those communities, face-to-face with the people that we serve, talking to them, gathering information from them, giving them information. So we've had to really adjust in the last 2 months to a new normal, as has everybody doing everything, but particularly for people who are outreach, which is a huge component of what we do. My background has been one where I've used technology to reach underserved populations historically. I came from the University of Kentucky, where we conducted a number of studies using social media and texting. And so that background has served us well. We used that in communities where people didn't think it would work. We used it in rural Appalachian people who were over the age of 50, for example. No one thinks of those folks as using Facebook, but we did a Facebook study with rural Appalachians over the age of 50, and they were very responsive to that study. We use community engaged strategies. We use community health workers, we use local folks, we talked about local things, but we use that to stand up our outreach and education surrounding colorectal cancer. Some of those techniques we're currently using, for example, this webinar that we're doing right now might have been a face-to-face talk out in public had we not been in COVID-19. Instead, we're all on Zoom, which allows people like my family who's on here to hear what I do, and other people who are in our communities to be able to listen to us. So I think our team has adjusted very well and has continued to reach out to our communities in important ways, using Zoom, using social media, using tweets or twits or Twitter. I can't remember exactly if you tweet or twit, but we use Twitter, we use social media, we use, and that's the beauty of having a team that has deep expertise. I think we brainstorm well, And we've been able to find ways that we know work well within the communities that we serve. We can work in Spanish and English and other languages. We can still use the same strategies we've been using, but we're reaching people more electronically in this time of the COVID-19 pandemic. And we're also developing our digital footprint, having a digital library and YouTubes and other things, other ways that we can reach people that are not necessarily the way we would want to reach them face to face. And I think we're gonna, when we come out of this, which we will, we'll have a much more hybrid way of reaching people. I think we'll have a much more connection digitally, and we'll also have our face-to-face connection, which remains important for people, particularly people who are not as connected electronically as some other communities. We know that there's some communities that don't have the same kind of bandwidth that others do. We do have a large metropolitan community in Maricopa County, the 5th largest in the country. So most of them are likely going to be connected in an electronic way, but we also serve tribes and we serve people who are rural who don't have the same kind of capacity. So we have to think of creative ways to reach them as well. I've got just the right team to do it because you all are constantly bringing me ideas about how we can better reach people.
And I think that's one of the greatest parts of this transition process was learning how we adapt and how we create a larger scale of our own internet outreach and how we formulate that and try to become better at it. So if nothing else, it's been definitely wonderful for us and our team to conduct our own goals and jobs in this manner, which Let's Talk About Cancer has been wonderful for everyone so far.
We just need Gabby to become a TikTok star now and promote
Oh, no.
education.
Oh, no.
It's allowed us to stretch, and stretching is always good. Stretching your boundaries is always good. It's forced us to think outside of the box, to think, you know, how are we going to reach our partners who we've been able to just jump in our car and go there and hand them something? How are we going to give them? Because cancer is not taking a break. Mm-hmm. Just because we have a COVID-19 pandemic, cancer is still having the same impact on people's lives that it did. In fact, the COVID-19 is amplifying that impact. We are seeing more food insecurity for people who already have cancer, which makes their treatment worse and makes their outcomes worse. It's exacerbating every disparity that was already out there for the communities that already experienced disparities. Those disparities have become more apparent and they've become much deeper. And when we come out of this, we'll see that health, unfortunately, I think health equity will have taken a bit of a back seat. And so we'll have to work, teams like ours will be central to working to try to balance that health equity again.
We were talking with Dr. Erdrich on Tuesday and how there was a news article that came out that since the pandemic has occurred and all the physical distancing that I think cancer screening rates has declined by 62%. And so again, that's going to be a big challenge.
It's going to be a huge challenge. And those screening rates, that 62%, I promise you will be reflected more in our underserved communities. Like I pointed out, our Navajo Nation, who's experiencing the pandemic in a way that's threefold how other places are experiencing it. They're not going to be able to concentrate on cancer screening at a time when they're concentrating on how to live through a pandemic. But cancer won't stop being manifest in those communities. They're just going to have to ignore those symptoms, which means they'll have late stage diagnoses. They'll have different things that will make those disparities much more apparent for cancer, and it's going to impact cancer treatment and care for years to come. And so we'll have to work doubly hard when this is over to be sure that the communities that are underrepresented and underserved are able to catch up, and that we're paying particular attention to their cancer prevention, control, treatment, survivorship, that we're paying particular attention to their needs.
Mm-hmm. And now along those lines of continuing our efforts to equalizing access, you are the founding member of DREAM program that's also known as Disparities, Researchers Equalizing Access to Minorities. Could you tell us a bit about what the program is for our audiences that might not be familiar?
I am happy to. It's one of my babies. I founded a program called the Dream program, and it's all about equalizing access. But by access, I mean more than just are you able to go to see a provider? By access, what I really mean is their health equity. The things I was just talking about with how people experience health and how they're able to access that health and have optimal healthcare outcomes. The Dream program looks at health equity in kind of a three-pronged way. It looks at the healthcare system. It looks at the research that underpins health equity, and it looks at communities. And the highlight of the Dream program has been the Dream Scholars. And that's developing a group of scholars who understand health equity, understand health disparities, and are using cutting edge scientific methods to advance health equity for a variety of populations. So I started this in Kentucky. It continues in Kentucky. The Dream program, the Dream Scholars program there is very vibrant, and they have a variety of health equity researchers who are doing research in a variety of populations. One of my favorite things about it is that the majority of the Dream Scholars are minorities themselves. As minorities, we are sometimes much more passionate about the health of our own people, and it's great to equip those passionate people with the skill set to be able to make a difference in the communities that they come from and represent, like Dr. Yellowhair, who's part of the Native American, the Navajo Nation, and has a huge skill set in health, in things that can change the health of her community, myself in the African American community, who I'm passionate about their health. And both of those communities, they're the leading communities in terms of health inequities, African Americans and American Indians. And so people who are equipped as scholars can do research that ask the right questions about their community and bring that science to those communities. So the Dream Scholars is designed to do that. We have scholars in Kentucky and North Carolina and now in Arizona who belong to those groups, but you don't have to belong to the group to be a Dream Scholar. You have to be interested in the health of a group. You have to understand health equity, health disparities, and how to design questions that are appropriate for those communities, and very importantly, to disseminate the findings to those communities and to the scientific community at large so that we can help to move health equity forward. And so I'm proud that I was recruited here in part to bring the Dream program to Arizona. And I've been able to marry the previous Dream Scholars with Dream Scholars here, like Dr. Contreras. I consider one of our Dream Scholars who is a part of our program and who does policy work and who has done work with diabetes and cancer. And Kelly Palmer, who's a pre-doc, who's interested in African American women and their cancer needs and creative ways and novel ways to reach those women and in barbershops or beauty shops. That's the kind of research you get with Dream Scholars, research that's relevant to the communities, that asks the right question, but that also uses techniques that are important to the community, and they know where to go to do that research. So we're developing a cadre of scientists here in Arizona, but I decided to keep some of those folks from Kentucky and other places on board to help make sure that we're having a national impact, so that we're not just impacting Arizona, but we're developing a team of scientists across the nation. The Dream Scholars are impacting the health of minority communities across the nation. We're from different backgrounds. We're nursing, we're policy, we're health systems. So the way to solve health inequities is to attack it from every different angle. And so the Dream Scholars come at it from a variety of ways. And when we get together in our brainstorming sessions, It helps us to have perspectives that I can't bring. I bring a really important perspective, having worked with communities, having been a nurse in the healthcare system, but we have health systems experts, we have policy experts, and you can't fix health inequities without working at every level, at an individual level, at a community level, at a policy level, at an organizational level. So what I've tried to do with the DREAM program is bring together nationally a group of people who represent all of those levels, all of the social determinants of health, who can ask the right questions of the right people, and who are equipped and experts in their field and can help us to change the way the nation looks at health and the way we attack health for underrepresented populations. So I could talk about the DREAM scholars and the DREAM program all day, because it's really my baby, and I think that we're going to change the way health looks in this country with programs like the DREAM program.
Right. And incredibly valuable to have for exposure to so many people. I mean, you've already done so much, but for it to continue to flourish as it has, kudos to you for all of that hard work.
It's a great team effort. We have a great team of scholars, particularly a great team of scholars who are passionate about it as I am, and who have deep expertise in what they know. And when you get a bunch of people around the table like that, who are passionate and who are the nation's and the world's leading experts, you can change things. And so we mentor people. Those of us who have been scholars for a longer amount of time are able to share how we work and what's been effective for us. But also we learn from the new scholars who sometimes have passion and they have new techniques and ways to do things that I've never thought of. So it's great to bring all these perspectives to the table. And I believe strongly this is the way we'll change the health equity picture in the world, really globally. But certainly we're going to start right here and have a national impact.
So that pretty much answers my follow-up question was, can you tell us a little bit more about your extensive interest in research health equity? So and maybe talk about a little bit more about the research projects that you're doing currently.
Yeah, so even like the DREAM scholars, we all have programs of research. And those programs are very different. My program of research, as I've talked about, my personal program of research outside of community outreach and engagement, is in cancer prevention and control. And so I've done research projects over the last 15, 20 years that I'm a population expert, so they're in various populations, but they're designed to help those populations prevent or control cancer within those populations. So one example of a research project that I have here in Arizona is the Moonshot Project. Dr. Lance might have talked about that because he started it and I took the baton as the lead PI for that project. And it's with American Indians and colorectal cancer. And the whole design of that research project is to look at evidence-based ways to prevent colorectal cancer in this population. And so we take a cultural look, we look at their electronic health records, we look at the systems where they receive their care and how the screening takes place. And we also look within the communities to encourage that screening. We know kind of what works. When there's health disparities, it's not because we don't already know what works, it's because sometimes the people that we have those disparities don't get that stuff. So the evidence-based interventions we take from things that have already worked. We know navigators work, for example. People who belong to populations who can be trained to go back to those populations, speak the language, understand the culture, and can be trained to help move their peers to action. We use navigation, peer navigators within the Moonshot Project. Moonshot is colorectal money that Joe Biden and company gave to help to cure cancer. We have used that money to help prevent cancer in American Indian populations across the state of Arizona. It's a consortium project, so we work with Oklahoma and New Mexico to understand regionally how to impact American Indian health. That's an example of the type of research that I do within communities. I've done that with grandparents who are raising their grandchildren to try to help them prevent diabetes. That's not a cancer project, but it's an example of how I design strategies to help communities prevent or decrease their risk for certain chronic diseases. We've done that with rural Appalachians, with African Americans. The thing that I think makes us a little novel is that we meet them where they are and use various techniques. So we've done faith-based work. And it's not faith-based, it's faith-placed. We placed it within churches in rural Appalachians who are a strongly spiritual kind of community. So we worked within their churches to get them to prevent cervical cancer, something that is difficult for them to talk about because it's sexually transmitted. We use their peers to help them, the women in rural Appalachia, to get more colorectal cancer screening. And it's called Faith Moves Mountains because it's in the rural Appalachian Mountains. That was a very successful project that I participated in Kentucky. And my sense is that the moonshot will also be a very successful way to increase screening rates in American Indians, and that it will go on for years and make a huge impact of how colorectal cancer impacts that population. If we can increase the screening, increase their utilization of that, we can drive down the cancer rates. And it's one of the top cancers that American Indians and people in Arizona experience. The screening rates are very suboptimal for American Indians, somewhere between 9 and 30% in Arizona. The national screening rates, 75 or 80%. Most people get screened for colorectal cancer, but certain populations don't. That's a huge health disparity. If we can change that, then we can change the colorectal cancer, the rates of people who get colorectal cancer. So that's the type of research I do, primarily in prevention. I work with people who do treatment research, who do survivor research, who do all the other research to help them engage communities. But my personal program of research is in prevention.
And through all of your experience, Dr. Hatcher, with these programs, what is the most challenging community-based intervention to conduct?
Well, they're all super challenging because working within communities takes a certain kind of humility. And anybody who's ever heard me talk has heard me talk about cultural humility, but it takes a certain kind of humility that you don't go in and think you know already what they need. And so it's challenging to have an expertise, but to have to pivot and adjust to the community's priorities. If people can't eat, for example, they don't care about screening. So screening rates are low in certain communities because their priorities are different. To try to have an understanding of how that works and still try to not force your priorities on them, but work with them within the framework that they live is challenging. It's the biggest challenge is most likely communicating that to my scientific peers, helping the people who also do the science to understand that we're not in an ivory tower and we don't get to tell people how to experience cancer or what to do, that our priorities, though we may be super excited about them, are not necessarily the priorities of the community, and that we need to bring the community to the table to fix a problem rather than trying to fix it without them in a room full of people who are the majority population, and then take it to the people and say, here it is, we can save you, we fixed your problem. So one of my biggest challenges is sitting at the leadership table for a cancer center and helping my cancer center peers to understand how to collaborate with the communities. The communities are usually super interested and grateful and excited that somebody wants to work with them in a respectful way. So I don't usually have problem with entree into communities because I understand how to use people who have entree into the community to help me be introduced and to be respectful and take my time and to begin to work in communities in ways that they want me to work. I have a little more trouble sometimes with my scientific peers, getting them to understand the importance of of working in these ways in the community. But when it all comes together, it is magical. So I just keep doing it, even though sometimes, as you point out, there are challenges to be overcome in each of these communities. But it's well worth it when you see a change in both those scientists who are in the majority population lots of times, and those minority populations who are happy that we're interested in changing health or changing the impact of health disparities for them. I hope that answered the question about challenges.
Yeah. And so an additional challenge I think that we're going to be facing now as researchers is the current pandemic. And so especially working with community-based projects such as the Moonshot that you mentioned.
Yeah.
Has this currently affected other parts of the research project?
Yeah, so if you do prevention research, you are straight on hold right now. There's no one doing prevention research, because you can't do prevention research when people are cancer prevention research when people are dying from COVID-19. You have to put that on hold. And for me, if you're a partner with someone, you partner with them to meet their immediate needs. So it's changed the way we look at research. And that challenge I talked about of our scientific peers, I think it's allowed them to see that we can't just be helicopter scientists. We can't just drop in when we want to make a new discovery and say, you know, we learned this on the backs of our African-American counterparts, and now we're famous and we're going to move on. And when people need to eat, when they need access to care, when they need immediate needs met, if you can help to figure those needs out, the social determinants of health, we all know now are the reasons why people have health disparities. So this COVID-19 has changed our perspective for a short time. Cancer is not going to stop. Like I said, people are still experiencing cancer. They're still getting cancer. Their diets may be even worse, which means because food insecurity, which means we're going to maybe experience some kind of surges of certain types of cancer. Like I said, those 13 obesity-related cancers, who knows if we'll have a surge in some of those. We know we'll have a surge in some of the things like cancers that could have been prevented by screening, because screenings are on hold. All elective procedures, and screenings elective, have been halted for now. So anyone who's doing research to promote screening, we can promote it, but they can't get the screening. And so we're slowly reopening. Elective surgeries are starting back. Elective procedures are going to start back. But people's lives will still be in kind of chaos. They'll still be staying home more. So we're going to have a new normal about how to do research that's prevention research. And I'm excited to have a new normal. It's always good to be challenged and get something, figure out a different way to do something. I think in the coming months, maybe years, we'll be figuring out, despite a pandemic, how to still prevent cancer, because we don't want to see the pandemic, in addition to cancer, take more people out in our communities than we need it to. So myself and other scientists across the country and the world are going to be, in addition to figuring out how to stop COVID-19, we're going to be figuring out those comorbidities that accompany COVID-19, cancer and diabetes and other chronic diseases that people experience, how to keep those from surging in communities of color particularly, but also in all communities, how to prevent that. So our research projects might be on hold, like the Moonshot, it's on hold. We can't encourage people to be getting screened. Like I said, I'm not passing out a fit test while people are trying to figure out a test for COVID-19. But I am trying to figure out ways that as soon as this is up, how we can catch people up, because we know they were already behind. So we need to just try to figure out creative ways to be sure they don't lag even further behind after this is over.
Mm-hmm. Yeah, that's one thing that I'm grateful about the U of A, that I've been noticing their response and assisting the Navajo Nation with PPE. There was a few of the scientific labs that actually put their research on hold and actually made hand sanitizers to hand out. They also have done, I think just yesterday, I can't remember how many tons of food that the agricultural program donated, fresh vegetables and working with another tribal college, Diné College, they actually trucked that all the way back up to the Navajo Nation. I think it was today. And then other ways that they're doing, like developing COVID-19 test kits. And so it's very remarkable seeing how the U of A has been responding for the Navajo Nation. And I know we're very grateful for that. And so I think it's just going to be a challenge, like to try to find ways to move on from here after all the physical distancing is lifted.
I'm glad you brought that out. I'm really proud of the University of Arizona and those responses that you talked about, because the Navajo Nation is an important partner for us. And like I said, when your partner's being pummeled, you can't just stand back. And the University of Arizona stepped up. And it takes voices like ours to keep them aware of that. That's why it's important for us to be at the leadership table, to say, you know, our partners on Navajo Nation are not doing so well. What can we do? That's why the DREAM program is important. That's why the work that we do is important. If we're not sitting at the table, you can kind of forget about us. And so it's important that we are at every stage of leadership and all the way through a university, so that we can give voice to the people who don't necessarily have a voice and are not always seen. Some of our partners are, you know, it's easy to say, oh, when you're dealing with 19 million people in New York, why do you care about 250,000 people on Navajo Nation, or us, you know, to forget about people who are in prison, to forget about people who are in rural settings. And so having everybody at the table gives voice to the people who might remain invisible if we weren't. And I think a lot of us gave voice at the University of Arizona and pushed that leadership into taking some actions that might not otherwise have been taken. We're well represented across the university, and I'm glad that we raised our voice and got them in motion.
Yeah.
Yeah, and one of the key points here that I think for our own community members to know is that the aspect that you spoke about, Dr. Hatcher, that it's on hold. It's not Pardon?
It's not over. Yep, just on hold.
It's not over. It's just on hold for a moment being, and everything is still going to continue in the efforts and the goals that we all have aligned.
Yep.
Which brings us to our next point, our upcoming webinars that we have. Next week, we have Lesbeth from the community, our Cancer Support Community Latino Outreach, and she'll be talking about outreach in that, in the various Latino communities that she serves. And that one, I believe, will be in Spanish.
Yes, it will.
Dr. Lana from Native Health, and he's going to talk about cancer care with tribal nations. The following other webinars are going to be in the following few days are going to be Tina Brown from Arizona Complete Health, Dr. Daniel Persky from the University of Arizona Cancer Center. We're going to be talking about clinical trials. And recently added, we have Rosie Vogel of the Arizona Cancer Prevention Research Group, and that one will also be in Spanish.
And I really want to say too, before you open up for questions, to really thank the team who put this together. You guys are doing an outstanding job, as you always do, but you have pivoted, you've put together these kind of programs, and they really make a difference to the people that we're trying to serve. So I really want to give kudos to this team for putting together not only this, but all the other efforts you have that continue to make us make a difference in the lives of our catchment area and beyond.
And for the month of May, we're also going to be switching it up again. We're not aside also with Let's Talk About Cancer. We're also going to be doing every Friday a cooking demonstration, and so we will send that information out soon, very shortly. So that way, if anyone wants to join us and learn to make some tasty dishes, especially for people who want to eat more healthier, so it's going to be interesting. And so here is our information. If someone has any questions, if they want to reach out to us. Also, more importantly, we have included a website to evaluate us on how we're doing. Is there a topic that you'd like to learn more about? You can either write it down or just take a photo of this QR code and scan it, and it'll bring you to the website. And as always, follow us on social media through Instagram, Facebook, or Twitter, and we'll be happy to answer any questions. And so at this time, like to open it up to our participants to see if anyone has any questions or if there's any questions on social media for Dr. Hatcher.
I checked social media. We currently don't have any questions, but again, our screen is up with our email. So if you do have any questions for us, please contact. Let us know.
And a shout out to my family who is listening to this, Letitia, and I saw my brother there because they're really super supportive, and Kevin.
Oh, hello, everyone.
You're really fancy, Mom.
Thank you, Letitia.
Hi, Dr. Hatcher, this is Octavio. I did have a question, actually.
Okay.
So what about health disparities when talking about these protesters and this push to reopen during the COVID-19 pandemic, knowing that, like you said, Navajo Nation is being pummeled, the Latino community, the African-American community. I've seen some alarming statistics that they're being disproportionately affected because, you know, they're more at risk because of the higher rates of the other chronic health conditions that disproportionately affect these communities. So what advice would you give to perhaps Governor Ducey or those that are considering or weighing their options at this moment?
That's a great question. I respect Dr. I think her name is Krista. Is that right, Omar? Who's over the ADHS response, the Arizona Department of Health Services. She's doing a great job. And I could, though, give some advice about disparities, like you said, to the governor and maybe the president and others. But and my advice would be to look at the social determinants of health when going back into this reopening, to consider that various people are overrepresented in various kinds of positions. So the reason that parts of the reasons that we're seeing overrepresentation by COVID-19 in certain communities is a variety of factors, including overrepresentation in certain kind of positions like restaurant workers and bar workers and grocery store workers. People are overrepresented in some of those occupations, but also overrepresented in the healthcare system in terms of chronic diseases. We have more diabetes, more cancer. We're more vulnerable if we do get it. So not only are certain populations at risk more for getting it, but they're at risk for doing worse when they do get it because of those comorbidities. So that should be considered in our reopening. If we're reopening what we call essential things, and those people, we're overexposing a certain group of people who are overrepresented in those occupations to COVID-19, we're going to exacerbate this disparity. We're going to make it worse. We're going to put them in positions which they're already in, where they don't have a lack of access to care, and also where they're experiencing less social distancing more than others. This is already the case. Bus drivers, grocery workers, people who are experiencing it differently. People have food insecurity, so their health is already worse, which makes you more at risk to have a bad outcome from this. So it means that the healthiest among us, the richest among us, the people like myself, I can stay home. I don't have to go into an office. They'll roll out people going into offices that have lower incomes before they roll it out for people who have higher incomes, meaning we'll place them at risk first. We don't want to test case things on people who are poor. And so the rollout needs to consider that. And so, like, I'm a big proponent, like I said, of putting a whole bunch of people at the table who are really smart. They need a health disparities expert at that table. They need a person who understands populations and representation deeply, health inequity at that table, so that this rollout doesn't affect certain populations more. The reopening doesn't affect certain populations more than it does others. It's going to. There's no way around some of it, but we should be as thoughtful as we can. That's a good question, Octavio.
So as a nurse, and I know it's going to be hard to do stuff, how can we help are your fellow nurses out? I mean, aside from staying in and not going out, is there any, and I know I asked this because my neighbor, she is a nurse and she works at the local hospital near where we're at. And she says that people are donating food for lunch, so they are well fed. But is there anything that you think that we could also do to help support the frontliners that are working in the hospital?
Yeah, I think this is a frontline that's experiencing something that no other generation of nurses has experienced. You know, I don't want to age myself, but I was a nurse when HIV was first I was a critical care nurse when we were just figuring out how to contain HIV. We weren't wearing gloves at first. Now, who would think that you wouldn't be wearing gloves? 30 years ago, we were just trying to untangle AIDS and HIV. This is a whole new animal for those nurses. And as a former ICU nurse, I think the important thing is to consider the emotional toll this is taking on our frontline workers. I've seen a lot of people die in ICU, and they're seeing people die like no one could ever imagine, and die alone without their family members. And you're their family member, you're at those bedsides. So emotional support, I think it's great when we are standing outside clapping for them. I think it means a lot to say thank you to those people who are for 12 or 16 hours a day watching people die from this and exposing themselves and their families to high risk. So I think it's stay inside. As an ICU nurse, you're putting my sisters and brother nurses at risk when we don't observe it. It's unfair to them to have to care for people who are not caring for themselves. So the biggest thing I think we can do is observe this social distancing, flatten this curve, and make sure that we say thank you to those people. They do it. I did it. I didn't do it for thank you. I did it because that's what we do. And they're not looking for thank you, but they need a lot of support. I think there's going to have to be a lot of programs emotionally for our frontline workers when this is over. I experienced burnout. I know a lot of them are going to burn out after this. You can't take this kind of trauma from day to day and not get some burnout. So I think we just need to be supportive. If you have family members or people who are frontline workers, you got to give them a whole bunch of support with their kids, with their families, with maybe just listen to them while they go on and on about what they are seeing. Because it's tough in those ICUs. I've seen a lot of it, but nothing like what they're seeing for the ICUs now. It's crazy.
Yeah, I saw something on the news where one of the nurses, she's like, I just felt like I got drafted into a war that I didn't know that I was in the middle part of. So, but yeah, so
if you're in a grocery store and they see people who are not wearing a mask or not practicing social distance, and they realize I've got to go back into ICU in 3 hours and take care of the people that you've exposed by being in this grocery store without a mask on, you can get pretty angry. Already you're watching people die, and you can get pretty angry saying, why won't you just, how simple is it for you to just put on a mask?
Yes,
just
please. Okay, well, if nobody else has any other questions, I'd like to thank Dr. Hatcher for joining us today. And as I previously mentioned, we are looking for additional programming like the cooking demonstration. So we will send out more information on that once our plan is fully laid out and solid. So again, if you have any other questions or thoughts, again, please reach out to us on social media. Our evaluations are available too. It's another great way to provide feedback. So with that, I would like to say thank you everyone for joining us, and I'll go ahead and stop. And thanks, Gabriella.
Thank you. Thank you so much, Dr. Hatcher, and all of the folks that were with us today. We appreciate your time.
Thank you. Bye-bye.
Thanks.